And ideally, as we're seeing them, think a little bit, if you're the front line nurse, what are we going to do or anticipate with those patients? So, 10-month-old boy, red rash. He's been crying all day. He's feeding poorly. Mom says he doesn't even want to be held. And he's got a low-grade fever at home. She hasn't measured it, but he feels hot. He was well yesterday, but cried with some diaper changes. Faint red rash in the diaper. She didn't really think much of it. She thought, oh, he's getting a bit of a diaper rash. Previously healthy, immunization's all up to date. And that's what, oh, that does project pretty well. That's what he looks like. And I'll give you the front position. This is what he looks like. So he's got redness, see around his eyes. He's a little bit crusty around his eyes, around his mouth. And he's basically got a sheen of red with maybe a couple of areas. Let me see if this pointer works. See here? It almost looks like he had ECG leads taped there, but he didn't. But these are more red, and there's maybe a little bit of peeling there as well on his skin. So at triage, heart rate 190. This guy's 10 months old. What do you think about that? Is that a red flag? That's a red flag, right? Respiratory rate 60 at 10 months. What do you think of that? That's a little high too, yep. What about his blood pressure, 80 on 58? It's okay. It's all right. You might pay attention to that. 38.9, so he does have a true fever. Sats are 98%, and he's just miserable. So he's alert, and he's looking around, but he's miserable. So, oops, sorry, I'm supposed to ask you now. What do you want to do? What do you think about this kid? So what might you triage him? What might you give him? So we use CTAS, and Sidra uses ESI, but ultimately probably this kid's going to get pretty close to the same triage level. So even if you don't triage, what do you want to do with this kid? Park him in the waiting room? Have him go straight back? Right? So anybody who does triage, I saw a 2 go up over here in the corner. 2, I see another 2. Any more 2s? Anybody want to make him a 3 and just bring him straight back? Maybe 3, so there's a few 3s. But I think probably we should all agree that he's not going to go sit in the waiting area, right? Tachycardic, a little bit tachypnic, febrile, miserable little guy. So whatever you ideally choose, it needs to be seen urgently. We're going to treat this with pain, for pain and fever. Do you think if he needs an IV, you might put in some EMLA on, but the trick here will be putting EMLA on normal looking skin, right? Because you don't want to put tape down on an area that you're then going to have to pull off. And we're going to assess him for hydration and feeding, and then possibly prep for a little bit of blood work. You think anybody's going to want blood work on this guy? Probably yes, right? He kind of looks yucky. Does anybody know what he has? Any ideas? And if you're not sure, that's okay. If you have not ever seen this, that's okay. Are we going to say infectious or non-infectious? Probably infectious, right? Am I hearing a few murmurs for infectious? So he's got a fever, and he's got changes in his skin. So let's say he's infectious. Do you think viral or bacterial? Bacterial, yeah. So even if you don't know what this rash is, you can think through, what does this look like? What might it be? And if it's bacterial, then you're going to want to do a bunch more stuff than maybe if it's viral. Now, I've just got a few other pictures of the same thing, and I'll tell you what it is. On this picture as well, there's this, it almost looks like a sunburn, right? So he's almost got this sunburn appearance there. This is a more dramatic version of it. And there's a little bit of a clue when you see this crusting. There's a bit of crusting on his face. Does that lead you to think anything? And then all of this redness. And it looks like a burn, and it acts like a burn, and it hurts like a burn. So the treatment of the pain is really, really critical. And it's why they don't want to be held. It's why they don't want anybody to touch them. It's very painful. And it can start, actually, and why the diaper area was significant, it actually sometimes can start in the diaper area and then spread out. And on dark skin, it can be a little tricky, but again, you're looking for something that looks like a sunburn. And then the most dramatic version where it's really embedded, and now you've got blistering and weeping. Again, it looks just like a burn. So this kid's going to get CBC, probably inflammatory markers, so at least a CRP. Going to look at his renal function and a bunch of other things. He's going to need IV fluids, hydration, and I can't say pain control enough. And he's going to get antibiotics covering staph and strep, and in particular, cefazolin and clindamycin, because he has staph scalded skin. Has anybody ever seen a case of staph scalded skin? So I got 1, 2, so 2. So it's not super common, but it's a really good one to recognize when you see it. So unwell, not necessarily toxic as in we need to go to a recess area, but unwell, yucky looking kid, looks like they have a burn and they're febrile with it. And basically it's a toxin mediated, so yes, it's bacterial, but it's the staph produces a toxin that causes the skin to slough, and it causes that burn. And so they can really be nasty. And it often will do that face, neck, and why I pointed out the crustiness around the face is impetigo, which I'll show you some pictures of in a bit. It has that crusty appearance. So when you see that in conjunction with something that looks like a burn, then you're thinking staph scalded skin. They don't get it on their palms or soles, don't get it on the mucous membranes, it's really skin. They'll crust, they'll scale, and then about 14 days later, it'll all kind of re-epithelialize, and you won't know that they had anything wrong, so it does not leave any scarring, it's so superficial. So, and I mentioned the antibiotics, and then the other thing is this guy probably not feeding well, so getting a good hydration status assessment is important, and if he's not, then IV fluids is the way to go, and those toxins are cleared through the kidneys, so you want to keep those flushing through so we minimize the disease. Now, what do you think of this one? This one I didn't attach a case to, but what's this? Any takers? So we see what looks like here a scab, so there's an injury about a week ago, and now there's pink streaking, and it's tender. Anybody? So cellulitis, yeah, so there's cellulitis around here, and then what specifically do we call that streaking? Lymphangitis. So this is now where the cellulitis, this infection, has gotten into the lymph glands or lymph channels, and it's spreading. So the risk with this is it's going to spread, and at some point they'll get septic and quite sick with it. So cellulitis with lymphangitic spread, if you just saw the cellulitis, you say, oh, you know, oral antibiotics, no big deal, home. This spread just means the fever is only moments away. Systemically, they may become unwell, so this requires IV antibiotics. How about this one? Other than ow, that hurts. So this is vesicular lesions that are very painful and sore and open on a child. Any idea what this might be? It's very localized. There's nothing anywhere else on the body. What if I told you the child had eczema? So if you have a baseline of eczema, what does that really mean for you? You have abnormal skin. So your immune system in your skin doesn't necessarily work properly. So it puts you slightly at risk for other things. And what if I said one of these lesions appeared on a lip and the mom had cold sores? So so eczema with herpetiform, yeah. So it could be from just mom or dad or somebody in the family or somebody close to the child has the HS1 herpes virus, so they get cold sores, and then this child in eczema can get this version of it. And so very nasty. They're generally unwell. It's quite painful. So they need treatment as well. And usually, if the timing is right, it's acyclovir or something like that. So this is a second case, 4-year-old boy, rash, low-grade fever. The rash started about 3 days ago. The reason I put this one in is I just saw one of these a couple of weeks ago at Sidra. Spread to the trunk and other extremities. He's now got oh sorry, this is not the case I saw. I'm getting my own cases mixed up. So fever started today. He's got some itching, burning kind of rash. Otherwise, he's really asymptomatic. So low-grade fever, rash. It started to spread. Otherwise, he's a well-looking child. And he's 4, so what do you think of the vitals? Heart rate 100. Is that okay? Yeah? Breast rate 20? Probably okay. Blood pressure? You okay with that blood pressure? And then the SATs are 100%. So his physical exam looks great, you know, when you're screening him, other than he's got these bullous lesions, various sizes, some crusting, and there's a bit of, and I'll describe what I'm saying in a second, but an erythematous base. So it's red on the bottom, vesicular lesion or bullous lesion, and it looks like that. So when the mom lifts up the shirt as he's coming into the ED or clinic or your clinical area, that's what it looks like. Other than kind of being grossed out, I can read your expressions from here really well. There's some people kind of going, ew, gross. What do you think of this one? Okay, infected chickenpox. That's not bad. That's not a bad guess. It's not that, but you're correct in that erythematous base with vesicles is how you would describe chickenpox. Yeah. And these are much bigger, and they never really were small. Any ideas? Now you'll note some of them are kind of clearish. You'll see some new ones developing. And see these ones? It's pus-filled. Yeah, so it's a version of impetigo called bullous impetigo. Yeah. So they appear on this sort of reddish base, right? Most of them have that bottom of the inflamed skin. And then the infection happens, and then they can get the blisters, but then they almost always then move on to being pus-filled. And so it can spread on the body. It can also spread to other people. If you saw this kid at triage, what would you triage them? How would you manage them? Is this kid going to go out to the waiting room, sit around on all the different chairs, touch everything, everywhere? No, no, right. So is he in dire straits and you want to make him an ESI that's high? I'm asking leading questions, terribly sorry. What do you think? Systemically well. Right, exactly. So you not wanting to keep him in the waiting area doesn't mean you have to triage him more urgently. It means you triage him whatever you think he is, which is a non-urgent patient because he's systemically completely well. But you're going to find an isolation room to put him in so that you limit sort of the spread of stuff. Yep, exactly. Staff included as well, that's right. So pretty much with this guy, it's pretty straightforward. We're going to do a little bit of contact isolation for him and then manage the fever if he develops it, because they can have a fever with this as well. And then what about treatment? What do you think treatment for this guy? And the key is systemically well. So oral antibiotics, yeah. If you had a really, really small area of regular impetigo without the bullae, you could probably get away with something topical. But with the bullae, and it's going to rapidly spread, so you really, really need something oral for that. So it's a superficial skin infection. It's a type or subtype or variant of impetigo, and it's very specific group 2 Staph aureus, so it's a very specific type of staph that causes it, and it's called phage 71. And it's another one that produces a little bit of a toxin that causes this epidermis to rise and allows the pus and fluid to form. Fancy word for toxin, but it's an exfoliatoxin. And it can appear, as I mentioned, just as that nice red little bit of skin. They get these flaccid, blister-like lesions, and then they become pus-filled. And once they break, it looks really nasty. And again, these are something that won't scar, even though it looks terrible when you first see it. They can actually get, interestingly enough, and again, it's because of that toxin, they can actually get diarrhea with it. So they can sometimes have fever, maybe a little bit of weakness, so they get a bit of muscle involvement, and then diarrhea. Doing a site culture is probably all you need. So one of the blisters that's broken, or you break one, do a little swab, try and get the base, not just the pus, and then treat systemically with a cephalosporin. And these tend not to be resistant staph, so the antibiotic choices are just the standard ones. So mom asks when he can go back to school and football. My original slide had hockey, but I'm in the wrong country to ask that now. So when can he go back to school? So what do you think? What'd you say, Bob?
No new blisters.
So no new blisters? It's good, yeah. So they're starting to crust over. And well, no fever is true. And then ideally, if he's been on antibiotics for 24 to 48 hours. Yep, so once you get on the antibiotics for a couple of days, you generally are pretty good after that. Now, what about this? So we just talked about bullous impetigo. So it started a few days ago with one spot, and it's just spread from his arm, just from his arm. And it's always been looking like this, just this crusty stuff. Someone said scabies? Did I hear that? So good, that's actually a really good point. This one is not scabies, but if they were smaller, and if you had any little clusters of them or linear lines of them, and if they were in between the fingers and toes, yes, yeah. Let me show you another picture of the same thing. So that's this lesion here, and there's a little tiny bit of this honey crusting there. So this is, so we saw bullous impetigo, and this is regular impetigo. This one, same thing. See this? So there's one little spot that this bacteria gets in the skin and causes this crusty, nasty-looking lesion. For this one, you could probably get away with something topical, and you want to apply it here, but you also have to cover off this other bits of stuff here. So topical probably will work. Oops, wrong way. This guy, probably you're looking, that's a lot of antibiotic cream to apply in this area, and you want to get rid of it, so we'll do an oral antibiotic on him. And this little one, how many people would put oral antibiotics on this one? How many people? No. How many people topical? Yeah, so this one probably same, right? So you might just be a little generous in your application, but once you kind of get the main bits of it, you should be good. And same thing applies. Once that's kind of crusting over, starting to fade, and they've been on antibiotics for a couple of days at least, then they're good to go back to school. This is just a bit more of a dramatic version of it that shows you can have the crustiness that's kind of yucky. There's a big technical word for you there. You can tell I'm a pediatrician. And then some of them will actually have that sort of yellow, reddish base, so they'll be more inflamed looking than others. But the whole package of it is impetigo. Okay, how am I doing for time? Good? Okay, so 3-year-old presents with a rash and a fever, 2 days now, getting more red, more widespread. Now he's refusing to walk. So he kind of comes in, looks uncomfortable. He's not toxic, but he's definitely uncomfortable. This is the one that I saw 2 weeks ago. Heart rate's 120. So in a 3-year-old, what do you think? High, low, normal? Acceptable? Okay, I'll take that. Respiratory rate 24, blood pressure 98 on 60. Everybody okay with those? Temperature's 39. So he's pretty febrile, right? SAT's 98%. And I'm going to show you a picture of the rash, but that's the description of it. So it's a mixed rash, and he's got red wheals or red circle areas. Macules are that sort of, half a centimeter or less flat. They're centrally clearing. There's some confluence, meaning they're all running together. And then some of the centers are violaceous, which is a fancy word for purple. And the palms and soles are involved, and I've red flagged that for a reason. And also, you note that his right knee is a bit warm and swollen. He's got decreased range of motion with that. So his big symptoms are joint pain and maybe some signs of inflammation, a big significant rash, and a fever. What question might you ask that will get you a diagnosis? What question might the doc ask, or nurse practitioner? And at least two nurse practitioners are looking at me like, what is she talking about? Okay. Okay, so I'm gonna let you in here on this. So previously healthy, ear infection 2 to 3 weeks ago, and got treated with amoxicillin. Okay, so there's my information that's gonna help. Nothing else, absolutely nothing else. And when you look at him, he looks like that. Yeah, so you could ask him about passing urine, yep. So no hematuria, passing urine, okay, yeah. And he doesn't have eye-lip involvement, yeah. So what do you think, does anybody has anybody seen a rash that looks like this before? So we've got, we got 2 over here. And this is, again, a little bit of an unusual. The impetigo and all these other things are good to recognize. This is not super common. This particular rash here is called erythema multiforme. Okay, we'll regroup on that. We got clapping over here. And what I was describing was these wheels, right? They're big round wheels, centrally clearing. They're running into each other, so they're confluent. And some of them, it's more obvious in this, but some of them are becoming purple in the middle. And that's very classic for sort of an erythema multiforme rash. Now, this guy, just go back one more here. So with those vital signs and that rash, and he's systemically not unwell, but he does have a fever and he's got joint pain, what would you make his triage level? I got a 3. Anybody else? So do you want him seen really urgently, or are you okay if he waits for a little bit? He can wait for a little bit, right? Yeah. So the only question on that would be, can we at least make sure he's got something for his fever and his pain? Because parking him out in a waiting area is probably not the best thing. But if he's a level 3, hopefully he'll be seen fairly quickly and can get some meds for that. So treat pain and fever. Unlike the staph scalded skin, where if you put Emlon and you put tape on, you risk pulling the skin off. This one isn't quite the same. That being said, you want to find an area that doesn't have a rash, which in these kids can actually be challenging. And again, because he's miserable, he's got a fever, assessment of hydration and feeding is proper. Now, obviously this is a different child, but remember I talked about palms and soles? So this guy also has rash on palms and soles. And there's a very short list of rashes in children, actually rashes in general, that actually affect the palms and soles. So if you see it, and I'll go through that list in a few minutes, that's actually super helpful, because you'll be able to kind of categorize, oh, this might be infectious, I should isolate them, or oh, this is a huge problem, I need to get them back to a physician faster, or a nurse practitioner. Now, when the rash first starts, it can actually look, that's not projecting super well. These are raised wheels. So this is actually, and I'll tell you what it is because you may not be able to see from a distance, but this is urticaria. So when this rash first starts, when this package arrives, it can sometimes appear like this. And so people sometimes will present to an institution or a physician or a healthcare provider and say, you know, I think I'm allergic to something, but I don't know what it is. And so they'll get treated as if it's an allergy, but then 24, 48 hours later, they look like that erythema multiforme. And it can also look like this, so bright red, and then the bright red grows, and then you get the clearing in the middle. So it's a very variable looking rash. And this is actually serum sickness. So you have the rash that looks like erythema multiforme, but could be the other versions of it. And why it's serum sickness is because he's presented with fever, rash, joint pain after an exposure to the amoxicillin. So it's a systemic type 3 hypersensitivity. Antibodies form complexes, and so it starts a whole cascade of your immune system, basically. And its clinical findings, you find the history of the exposure. So almost every time I ever see erythema multiforme, I ask about this, whether they have the joint pain and the fever or not. And usually, if it's going to be serum sickness, it'll present 7 to 21 days later. I think there are pockets of it. We used to see a lot of it in Nova Scotia, but I've certainly asked colleagues here, and there seems to be, I think, probably population-based differences. So they can get fever, lymphadenopathy, rash. They can actually get muscle pain as well, and they can either have the arthralgia, which just means their joint is sore, or they can actually have the arthritis, which means you're actually seeing signs of inflammation, which this boy has. His joint is swollen, he's got decreased range of motion, and they're tender. Very rarely they can get neurologic consequences. So it usually self-limited lasts about a week, but can last up to 3. So when parents come in and they see this very dramatic rash, it's often, don't worry, it's okay, you don't have to do anything, it's supportive care only. And they're looking at this rash going, really? And then you have to tell them it might get worse, and it could last a week or it might last 3. So often that's actually the biggest problem managing this, is managing expectations about it. And that certainly was the case with the family that I saw here. So in terms of when you're looking specifically at serum sickness, you can have this bunch of different rashes. So maybe it looks like urticaria, maybe it looks like this other rash, which I'll describe in a second, or it's as we saw with this nice big erythema multiforme. And erythema, to confuse things, erythema multiforme can be caused by other things. So you can have viral reactions, mycoplasma, there's all kinds of things that can cause erythema multiforme. The only thing that makes this different as serum sickness is the fever and the joint pain. So in terms of rashes, urticaria, as I mentioned, this one comes out a little bit better. So this is urticaria, so the raised wheals everywhere, incredibly itchy. This is a scarlatiniform rash, which can sometimes also, this can start as that, which is basically a fine sandpaper. When you rub your hand across it, it almost feels a little bit like sandpaper. Lots of little spots, something that you would see with scarlet fever. And then you can actually have, this is really impressive. It's not showing up as dark as it does on my screen, but this whole thing here looks like a giant bruise. If you just saw that in isolation, you'd wonder what on earth is happening to this child, or what has happened to this child, because it can almost be sort of purpuric. But then the red rim around it sort of gives it away as a gigantic macule. And then here's that early phase where you're seeing some red, and then all of a sudden you say, oh, wait a second, this looks like it's clearing in the middle, still has that red rim, and then some of these have gotten more purple as time goes on. So it can be very impressive. So this is erythema multiforme. This is a morbilliform rash, big red spots everywhere, and that will appear in your hands and feet as well. And that can be just a drug reaction, but not all the other bits and pieces. And then palms and soles, big list of medications that can cause it, and the ones that we would see most often in pediatrics are the antibiotic list there. And so a lot of these other things we don't see very often in pediatrics, which is why we see it probably less than in some things. So just a note on rashes on the palms and soles so that you're really cool. Rocky Mountain spotted fever we are not going to see in Cutter, just saying. But Coxsackie we might. So the enteroviruses, so if there's a little bit of GI distress, or if they have hand, foot, mouth, those kinds of things, those will obviously appear in your hands and feet. Secondary syphilis, which I gotta say we're not seeing very often in pediatrics. If you see it, it may be in the neonatal period if mom had it. Bacterial endocarditis, those are red bumps that can be sore. Kawasaki's, they get red palms and red feet. Scabies, as I mentioned, anything between the fingers and toes. Erythema multiforme, as I mentioned. Measles can also appear in the hands. Toxic shock, the morbilliform rashes. If you see petechiae and purpura on the hands and feet in the context of a sick kid with fever, that's one that you want to panic, well, sorry, I shouldn't say panic. Move quickly to the resus area, but calmly, because that will be meningococcemia. Reactive arthritis can sometimes put lesions on the hands as well. And then there's eczema and psoriasis, which look completely different, but also go on the hands and feet. So this is pretty much it. There's not much more out there unless it's super zebra rare to go on the hands and feet. Am I good? Time? Okay. So in terms of you're trying to sort this out, does this kid have this weird thing called serum sickness? The only thing that you might note is an elevated ESR or CRP, which guess what? You're going to potentially see that with a bunch of different viruses and bacteria. You can see some changes in the CBC, but that again is not specific. Sometimes you can see hematuria and urinary renal involvement, but it's actually very rare to see acute renal failure. And then nobody orders cryoglobulins right out of the gate. So if you're really struggling with the diagnosis, you might order a C3, so complement 3 and complement 4. If that's decreased and your cryoglobulins are up, then that will help you. But that's not usually emerge-based testing. So if they have not stopped or are still on the antibiotic, then or the medication, you're going to stop it. Supportive care. If they're in that urticarial phase or they still have urticaria and itching, you can use antihistamines. They're somewhat limited success. What we tend to do is use cetirizine or one of them that you can dose twice a day, that you also have a little bit of flexibility in the amount because they often will need more than you think they do. NSAIDs if they don't have any renal involvement. for that arthritis, because that'll tend to work better than acetaminophen or paracetamol. And if they're really severe and really distressed, they can get, and again, not something we would necessarily start in the emerge, but we would certainly consult rheumatology maybe about, because you're really treating the joint pain at that point. And so sometimes they get a short course of steroids, but that's unusual. So that's serum sickness. This guy, if you could actually input a picture on the internet, do you know how often this guy shows up when you Google images? It's crazy. So he's just showed up at triage. What are you going to do with this guy? Pinch his cheeks, yes, gently. So what do you think of this rash? Measles, okay, so that's actually a really, really good point. So he's a little flushed, got these nice red spots everywhere, absolutely no respiratory symptoms, no respiratory symptoms at all, but he had a cold maybe a few days ago, a week ago, and his cheeks are really, really pink. Okay. Anybody? So anybody here fifth disease? Fifth disease? Okay, so slapped cheeks, body rash, fifth disease. And it can be caused by a whole bunch of different viruses. Anybody know what the big virus is that causes it? Bob's like, oh, I should know this. I can try and remember this. Anybody? You don't like rashes? No. So it's a number of different viruses that can cause this one. And it might look a little bit more dramatic. And they're generally pretty well, and the rash tends to come on a few days after. This one I bring up because if you're seeing this, there is some risk to women in their second trimester of pregnancy. So if mom was pregnant, if just a nurse is looking after the child is pregnant, then we tend to say, you know what, fifth disease, you probably should stay away. And it's one of the parvoviruses that cause this mostly, and in particular, that's the worry. I have seen a couple of cases here, but not a lot. Now, what's this one? This one? So we've got red base, vesicular, chickenpox. And so what we learned in medical school was dewdrop on a rose petal. So red base with a little tiny drop on the top is chickenpox. Dewdrop on a rose petal. Now what about this one? This one is not vesicular. I don't know if it's transmitting as well, but it's sort of hard and pearly. And it started with a few. It's been there for 3 or 4 weeks now, and there seem to be more appearing, completely painless. Child is completely well. Yeah. Anybody else? Erythema nodosum? No. How about, and if I tell you it's in the wart family? Molluscum contagiosum. So molluscum contagiosum, which are little pearly, and from a distance you might think, oh, have you got chickenpox? But there should be no real redness associated with this at all. And they're not skin tag-like, but they're little bumps that feel like skin, and they're actually warts. And parents always say, oh, we burn them off? We burn warts off all the time. But these ones you should leave alone, A, because there can be many of them, B, because if you try and burn them off, you can make more of them, and C, they can scar if it doesn't work. And I've seen one case of toxic shock after someone tried to burn these off with cantharum, which is a beetle toxin, oddly enough. So leave them alone. They may take a couple of years to go away, but they will absolutely go away on their own. They're not super contagious, so it's not like, oh goodness, you have to, avoid swimming pools and not share stuff. They're not that contagious. They can be transferred within families, obviously. So we just say general protective cautions, don't share your towels, but generally speaking, it goes away on its own. And I think this is my last case, and do I have time? Okay. So 12-year-old, a fever, sore mouth. He's actually got a little bit of blood in his pee. He noticed his pee was a little bit red at home. He's got red eyes, and they're irritated. He doesn't have a lot of discharge with it, but they're sort of red and irritated. And he's had a bit of cough. He's had a cough for about a week now. He looks uncomfortable, but he's definitely not unwell. His respirate is 100. What do you think of that in a 12-year-old? That's okay, right? Respiratory rate 16, blood pressure 100 on 60. He does have a fever, 38.9. Sats are 99%, and you see red eyes, peeling lips and mouth, and I think I'll show you the picture. Kawasaki's, good girl. So no, but that's where you should, that's where you should go with this, right? So, but he's 12. So what age do we see Kawasaki's? So sort of 5 to 6 months to 5 to 6 years generally. So if he's 12, he's really atypical, but it's in the differential, right? This is a tricky one. So how would you describe what he has? So he's got maybe urethral involvement because he's peeing a bit of blood. He's got eye involvement and lip involvement. So he's got a mucositis, right? So he's got inflammation of all of his mucosa. So he's got a mucositis. So no way that you're going to be able to tell at triage exactly what this kid's diagnosis is unless the mom says, well, he's on chemotherapy or he's been diagnosed with Behçet's and he's got arthritis with it. There's no way. But what you can identify is that he's got a fever and he's got mucous membrane involvement, and that, what do you want to do with him? How are you going to triage this guy? He's systemically well. Right, so that's the answer. So it doesn't necessarily mean you have to make him a 2, but you don't want him to sit around and wait for a long time because he's got mucosal involvement. You've got lots of mucosa inside as well, and so it's not really clear what's going on with this guy. So you do want him seen semi-urgently, although that doesn't necessarily mean that you need to triage him a 2. You can still triage him a 3 and have him back soon. And he's febrile and miserable, so that kind of, and if you figure he's going to need some investigations of some sort, then. So treat pain and fever, hydration, drinking, eating, all that's important. Because this guy, and I'm going to tell you this because you wouldn't never guess it. So mycoplasma pneumonia, which we think of as the walking pneumonia that we see, we treat kids with azithromycin, clarithromycin, sometimes erythromycin, although that's a terrible, nasty thing. This has been described over the last probably, I'm trying to think now, 15 years or so. And so not a very fun thing to have. People thought, oh, is this some variation of something called Stevens-Johnson's, which is a terrible, terrible disease to have. But it looks like it's a mycoplasma pneumonia-induced rash, although most people don't actually have the rash. And the kids tend not to have the rash. So they get mouth, urethra, eyes. You may have that history of a cough. It's worth doing a chest x-ray, particularly if they have a pneumonia, to kind of get a little bit of a look to see and make sure that they don't have something there. In terms of testing for it, the PCR for mycoplasma, so the throat swab that most places can do for mycoplasma, if you get that back and it's positive, pretty much you got your diagnosis. You can also do serum titers for mycoplasma, not necessarily done everywhere, but you can do those as well. And then basically you treat with antibiotics, it's supportive care, pain control, you treat them like you would a chemotherapy patient that has mucositis. So there's nothing different about the mouth care for this than there would be for that. If it's really bad, sometimes they do get systemic corticosteroids, and if you had Stevens-Johnson, which is an extreme version, not necessarily caused by mycoplasma, then IVIG has been entertained, but it doesn't seem to have a role for this. And I'm going to show you another picture of what the worst case scenario kind of looks like. This is actually from an article published in the New England Journal of Medicine. And this poor guy, this guy's 18 or 20, and he's just peeling off in his mouth. So he's got an NG in for feeding because there's no chance this guy's going to want to take anything by mouth. But with treatment, this is what he looks like 2 weeks later. So if you can get past the initial infection and illness, they heal up pretty well. But it looks gross. Now, Poonam, what is this? What is this, everybody? Kawasaki's, yes. So Kawasaki's, strawberry tongue and red lips. So what else do we get with Kawasaki's? We get red bloodshot eyes, just like you saw in the last guy, which is why he was on the differential. Red swollen hands, feet. You can get a rash, and the rash in Kawasaki's can look like a variety of things. And then the fever. What they don't have in the criteria, but probably should, is irritability, crankiness. Has anybody seen a kid with Kawasaki's? Anybody not seen a kid with Kawasaki's? Let's try that. Has everybody seen Kawasaki's? Yeah. Have you ever seen somebody with Kawasaki's that wasn't cranky? You have seen a Kawasaki's without cranky? So if you've seen a kid with Kawasaki's without cranky, I would challenge the diagnosis. Because they're all so cranky. Now, this kid has same looking thing, but what if I say the sore throat and a rash? Scarlet fever, yeah. So the scarlet fever tongue and mouth can look very similar to Kawasaki's, which is why that's also on the differential. And if you look, it doesn't show up very well on the slide, but this kid back here and sort of around her face, she's got this fine sandpaper-like rash, which would kind of cinch it. They don't necessarily have the florid tonsillitis. Florid tonsillitis like you would expect in a straightforward strep throat, but they'll have a red mouth and red tonsils there and may or may not have pus on it, but that's scarlet fever. And the rash there as well. There you go. Any questions about that? Did I make that too hard? Ooh. Okay, apparently my time's up. No time for questions, so sorry. We good?
Any question from the audience?
Somebody really doesn't want you to ask me any questions. It's not me. Okay.
We don't have question from the opposed.
Okay.
So. Thank you very
Thank
much,
you.
Dr. Barb. Now let's go to the rapid fire. Our first speaker is Dr. Tony. May I call on Dr. Tony on stage, please?
Hi, how are you all doing? Good? All right, so my name's Tawny. I'm a nurse practitioner with the Sidra Child Advocacy Program. I'm going to spend the talk talking about child protection in Qatar and basically go through what the program does since we've been opening. I don't have anything to disclose. Talk about some of the challenges that we've faced thus far, and then go over some of the opportunities that we have in the future. All right. So we opened in January of 2017, and so now it's just about 2 years that we've been opened. Every year we hold a child abuse workshop. So this is where we pull together different stakeholders from within Qatar who are working and exposed to child abuse issues. There was the initial child abuse workshop before SCAP opened, and then in 2017 we had our second one. We also invited a consultant to come over from the States to provide a 3-day training about forensic interviewing. So this is how to approach the child when there's a suspicion of abuse, how to talk to them properly, how to see if there's anything going on without asking leading questions or being able to have a sound interview that would be held up in court. Okay, this is just a picture from the forensic interview training that we had. It was attended both by people within Sidra and also people within the community who work with child abuse. Okay. We spent a lot of the first year doing a great deal of outreach to different professional organizations within child abuse. So some of you may be familiar with AMAN, or they're also known as Protection Social Rehabilitation Center. They provide support services for women and children who have been victims of abuse. We also met with forensic medicine. These are physicians who work under the Ministry of Interior, and they are the ones who can legally conduct the examinations for children when there's a suspicion. So some of you have seen children presenting with bruises or significant marks on exam. They would be the ones to take the pictures, and that can be used in court. Similarly, for sexual abuse or sexual assault cases, they can do the examinations, collect forensic evidence, and again, have that submitted to court. Are any of you familiar with NOFR? No. So this is an organization that provides support for individuals with substance abuse issues. We also met with a lot of the schools out in the community, and also reaching out to Hamad Hospital, the pediatric emergency centers, and the primary healthcare clinics. So this past year, in 2018, we created a safeguarding module that was launched throughout CIDRA for all clinical staff to complete. This was also going to be introduced to Hamad staff as well. This is the starting page of it. Some of you may have seen that. We've had a pretty good completion rate so far, about 90% across specialties. We also developed an SCAP registry. So this is a database that tracks child abuse cases. There hasn't been really one that's central for Qatar so far. So in 2018, towards the end of it, we started doing this. We're hoping to collate information as we get reports and as we see the cases that can then be used to demonstrate national figures. We had our third child abuse workshop this past year towards the end of it. And we also had a short film titled Sorry. Some of you may have seen it kind of looping through in the emergency department television screens. And this is supposed to be up for a public awareness campaign. If there are any concerns of abuse, it has our information, how to contact us. And in this same promo, we also launched our child advocacy helpline. So this is a number that is available for the public to call if they have any concerns. These are just some stills from the short film. And it has the helpline number on there and also the name of the clinic. This apparently also won a Cannes Film Silver Dolphin Award, apparently. So some of our figures, so this is a comparison between the first year that we were open and last year, up through November of last year. So for the most part, when you look at our referrals, about 60% of the referrals coming in are for physical abuse concerns, and then it's followed by a quarter for sexual abuse concerns. And in terms of our demographics, it's a little more females versus males. The largest age group that we get referrals for are between 5 to 12 years of age. And in terms of nationality, we have about 60% non-Qatari to 40% Qatari families who are referred. So between the 2 years, it's interesting, the information has stayed about the same. For the outcomes, so these are the cases that we ultimately end up seeing, and when we see the cases, what ultimately happens? Do we confirm that abuse happened? Do we rule it out? Are we unsure? So for about 20–25% of the cases that we see, we say, yes, abuse has happened, or we're very concerned or suspicious that abuse has happened. We're able to rule out abuse in about 30% of the cases, all right? Another big thing that happened last year, as you all are very familiar with, is the ED opened in July. So with the opening of the ED, this really helped with streamlining the referrals for child abuse cases. So in the past, we would, for example, have a child who present maybe to Hamad Emergency or PEC, and I'll just think of a case that we had of a boy where there was a concern of sexual abuse by an older boy. He initially presented to Hamad Emergency. After our ED opened, we were able to have him come directly to CIDRA, and SCAP was notified prior to the transfer. We were able to contact the police to help direct the parent over to make the police report. We also coordinated with forensic medicine to come to CIDRA Emergency and perform the examination on site. In the past, oftentimes the child would have to go to the forensic medicine location, or they could potentially be seen a little later on wherever at Hamad Emergency or PEC. All right. So instead of having the child and the family go to multiple locations, now if we can kind of centralize everything, we can do that a little easier at CIDRA. Some of the challenges that we've come up with. So we're still very early on in the development of the program and also in the development of the child protection system within the country. So there's been a great deal of collaboration between, for example, us and police, the court system, with community agencies like Aman, but we need more. We need greater communication so that we can share information easier. We can have a more coordinated response. So, sometimes the families still do have to go to multiple places. If we can try to bring everyone to where the family is rather than having them go to multiple places, that would be potentially less traumatic for them. In terms of the knowledge gap for child abuse, it is a specialty. So if we can, for example, within law enforcement, have a dedicated child abuse team within law enforcement. Similar to schools, if there are identified people where there's a child abuse concern, they can have that school person respond. Also with the medical professionals, special training regarding child abuse concerns, if we can have a team, and that's what SCAP is filling right now, that would be helpful to move things forward in a more coordinated way. Resources, so we are struggling, for example, with our clinic space. We have a couple days where we have our clinic space, but within the emergency department, it's been very helpful when we have emergency cases that can't be seen on these clinic days, where we're able to use the emergency space for these families. Staff who are properly trained in child abuse, and for example, with forensic interviewing of children, we're working to build up the team who has those skills. Same with the medical examinations and having the medical knowledge there. Within the community, we can see a lot of these families, and ultimately we need to refer them out or offer continuing support for them. We don't necessarily have all of those supportive services in place currently, but it's something that we can work towards. And having stronger legislation is something that will take time. It's going to take a matter of years before we can have stronger child protection laws here. Some of the future opportunities that we have. So in 2020, we actually, in Qatar, we will be the host site for the Isbakan Regional Conference. So this is an international society for the prevention of child abuse and neglect. And they have regional conferences and also international conferences. So we have been awarded as the host site in a couple years. When I mentioned the database, we're hoping to, over time, be able to collect this information and have national data that can be helpful to determine, for example, what our baseline rates are here for child abuse, and over time, if we have interventions in place, are they effective? How can we move forward with this information? I talked about the ongoing collaboration. We are talking right now, but we need to meet together more regularly. We need to be able to be comfortable with each other, be able to share information rather than, holding on to information that could potentially be harmful to the families. And also providing more education. This is also going into the training that we have. We'll be working with the CAMS team at CIDRA with their medical resident training. We're one of the specialties that they'll be introduced to. So that'll be great to increase their knowledge of how child protection issues work within Qatar. This could also be a potential movement forward for training of nursing students down the line. Talked about some of the prevention programs that are needed. If we are able to engage the community further we need buy-in from community leaders, religious leaders. We can't do this on our own. It's a community issue, worldwide issue. And then also some of the legislation that we need, right? So we have a committee that meets together where we have stakeholders, again, from the community, and they're really the ones who can push forward policy change and stronger push for legislation. All right, that's it. I wanted to get some feedback from the group, though, in terms of your experience with cases coming in. How has that been so far when there have been child abuse concerns or referrals to SCAP?
Okay, I think this one has the feedback.
Let's just take some questions right after each speaker in case the speakers have other commitments. But for the feedback, here we go.
Hi, Tony. Where do you draw the line of culture versus child protection as frontline staff?
Sorry, can you repeat the question?
Where do we draw the line between cultural, cultural processes to child protection as frontline staff?
So I think a lot of it right now, again, there are a few different levels. The cultural practices and cultural beliefs are very central to how we practice, right, and how we carry out our approach to concerning cases. So we also are working where we need stronger laws and stronger kind of support to back us up. And without that at this point and without the policies currently in place, the best thing that we can do is really trying to engage the family rather than using more of an accusatory kind of approach, because if they're not coming through the door to us, we're going to lose them. And ultimately, if we come at them at a very, harsh, judgmental way, it's more difficult to reach them to talk about, what are the issues going on, how else can we support you, what other services do you need, what does your child need, and for example, with physical, as an example, physical discipline. So there can be, it's a wide range of what someone might be okay with versus another person. But, if we just say, you can't do this, and if you do this again, we're going to take away your child. One, we can't take away the child at this, there's no, that just doesn't exist right now. So, and they might not just come in and be engaged with us anymore. So if we're able to have continuous dialogue with them and talk about, are there family issues at home? Is the child struggling in school? What's going on to cause you to, hit him or her this way? I think that that would be the best approach.
Any other question from the audience? How about that? There's no question. And as for the feedback you were asking, Dr. Tony, from the front line, I think the standard or the guideline is really working very, very well. The collaboration between your department and PEC is really, really good. So we are catching a lot of cases and we are reporting those, rest assured.
Yeah. Thank you.
Thank you, Dr.
Thank
Tony.
you.
Let's go call on the next speaker, Ms. Mayola. She is a staff nurse from PEC Alstad, that she will be talking about updates in IV infiltration.
Good afternoon, ladies and gentlemen. I'm Ms. Mayola Pais, RN PC Alsad. I'm delighted to deliver a talk about trends in reduction of IV site-related complications. To begin with, I have nothing to disclose. At the end of my presentation, the attendee will be able to explain best evidence in reduction of IV site complications. Placement of an intravenous cannula for administration of parenteral therapy is one of the most common invasive procedures performed in hospitals. Intravenous therapy is an important part of treatment of many hospitalized patients. Although considered essential and life-saving, it has its own pros and cons. Nothing worthwhile is ever without complications, quotes Nora Roberts. Likewise, IV therapy is no exception to this. So, if you are administering intravenous fluids or medications to a patient, be alert for signs and symptoms of complications and know how to intervene when they occur. Remember the age-old saying, "A smooth sea never made a skillful sailor." Likewise, we nurses are faced with challenges and a multitude of complications encompassing each task. Let us now focus on some of the most common complications, namely infiltration, phlebitis, thrombophlebitis, extravasation, infection, and hematoma. I won't be discussing in detail as we are just going to focus on one single one. So the next bothersome question is, who among them is the cream of the crop? One of the studies conducted by a children's hospital in the UK reviewed the prevalence rate of infiltration and extravasation in pediatric patients. The results reporting infiltration in about 2.9% of the cases and extravasation in 2.3% of the cases. Another study conducted in the Netherlands in one of the neonatal intensive care units aimed to quantify the incidence rate and type of complications. They concluded on the grounds that 56% of the IV cannulas were removed based on one single complication, and that was infiltration. To sum up, both the studies concluded that infiltration is the leading complication among the rest. Early detection and the need to focus on prevention is the key. Empowerment of staff by means of educating pediatric nurses to deliver holistic care of IV therapy can make a huge difference. Clean hands count. Hand hygiene tops the charts. However, studies have shown that healthcare providers wash their hands less than half of the times they should. Site. Appropriate site selection and avoiding the flexion joints, such as the wrist and antecubital fossa, are crucial in preventing infiltration. Size. Use of the smallest gauge cannula is recommended to prevent infiltration and also to promote adequate blood supply around the vein within the cannula. Use of sterile, transparent, semi-permeable dressings that promote site visualization are recommended. Touch the IV site for any signs of temperature change or leakage at the site. Look if the IV site is dry and visible at all times, and compare the IV site with that of the opposite limb for any signs of swelling. Well, that's to say, half the battle won. Several studies and randomized trials have been conducted. One of the study, namely improving the visibility of intravenous site in pediatric patients, emphasizes that use of a sterile, transparent, semi-permeable dressing helps to reduce the incidence of infiltration. This is because IV nurses or the primary care nurses are able to visualize the IV site without having the need to remove any additional bandage over the site. Another study compares the role of replacing IV cannulas when clinically indicated opposite to that of routine. So this study emphasizes that there is no evidence of benefit in changing IV cannulas every 72 to 96 hours, thereby pointing to the fact that changing of cannulas only if clinically indicated. Another study demonstrates the role of an IV therapy team. This is because an IV team can make a significant difference due to the standardized insertion techniques followed by the team and also frequent inspection of IV sites by the team. So, our practice in Pediatric Emergency Center reflects all of these above current evidence-based trends, which we are immensely proud of. Our strength lies in our success. Here is a graph of where we rank in terms of quality indicator pertaining to IV fluid infiltration rate in PEC Al-Saad over a period of 1 year between November 2017 up to November 2018, with the highest percentage, 0.34% in March 2018, and the lowest, 0.00%, which is our target value, in July 2018. The Infusion Nurses Society recommends that the acceptable rate of infiltration in any given population is 5% or less. So we are proud of this performance, which mirrors our staff compliance with standards of IV care and delivery of safe, efficient, patient-centered care. Nurses are the foot soldiers of every patient care. What makes us shine among the rest? Well, the answer lies within each of us. Attributes such as critical thinking, which involves appropriate site selection and use of the right cannula size. This is all about critical thinking. Accountability involves caring for and monitoring of the IV site. Focusing on active listening and observing non-verbal cues is all about paying attention to detail. At the end of the day, always remember, they may forget your name, but they will never forget how you made them feel. Thank you for listening, and have a great evening, everyone. Here are some of my references. Thank you once again.
Okay, do we have any questions for our speaker? None. Can we? We don't have also question from the app, so we can proceed.
Let's call on our next speaker. That's Mr. Carlos, talking about nurse-led discharge within the ED.
Hi, my name is Carlos. I'm one of the nurse practitioners in the emergency department at Sidra. Sorry. So I'm going to try to be really quick and fast, okay, because I know everybody's tired. Last year, I came to talk about nurse practitioners. This year, my topic is about nurse-led discharge within the ED. Both are a huge responsibility in the emergency department and make us more independent. So before I start, I don't have any relevant financial relationship or disclosure to make. And at the end of this topic, all of you will be aware of what is the nurse-led discharge, the role of the nurse-led discharge, and the need of the nurse-led discharge in the emergency department. So, in principle, discharge a patient from the hospital is a medical decision. However, it can be also delegated to another professional, like us, nurses. But should be some safeguard in place at all time. Right. So, what is the nurse-led discharge? Sometimes we misinterpreted this. It's not about transfer all the responsibility from the doctor to the nurse. In fact, the nurse-led discharge is the delegation of the responsibility from the doctor to the nurse with a criteria, okay? But it should be we should have a plan in place that is being agreed with the consultant in charge, okay? Overall, the nurse should be willing to take this responsibility and have the knowledge. We can talk about two kinds of nurse-led discharge. The one that is more related to the work, where you know what is going to happen with that patient. For example, your patient comes for a tonsillectomy, so you have a previous plan and you know what could it be the outcome of that patient. In our emergency department, however, we don't know what kind of patient is coming through the door. We don't know how the patient is going to respond to the treatment. So it's more like a tailored plan over a plan that is already made. let's talk about the do's and don'ts about nurseless discharge. So, as nurseless nurse, we should take the responsibility to initiate the process. We should know how to do a full assessment of our patient. That means that we need to carry on our stethoscope, listen to the chest of the patient sometimes, and take more responsibilities of our patient. At the same time, you need to chase your investigations because that will make the patient go quickly home, all right? And you should follow the plan that is pre-made by the doctor, okay? Do this patient need a follow-up? Is the medication ready if the patient is gonna be discharged in an hour? And overall, act as an advocate to the patient. So you need to give full education to the patient, full education to the parents, and be aware that that patient needs to be safe to go home because you don't want him or her to come back to our department. What we don't know, we don't do as a nurseless discharge, is decide when a patient is ready to discharge. I will explain this more into detail later. Don't wait for the doctor to make decisions. Most of us know what to do in the emergency department, and we should take some decisions sometimes. Discharge according to different rules. That means that if the charge nurse, Andrew, is today on duty, we do one thing, and if the charge nurse, Rocio, is in duty, we will do something else. We need to be consistent with that. And always, as I said before, prepare your patient. Do not discharge any patient. It is not ready. So, who can do this role? Probably almost all of us, okay? You should have at least 3 to 5 years experience in the emergency department, being able to assess the patient and take some clinical decisions. That's really important. But also you have to have some expertise, and there should be some training and some competencies in the department. You need to have the support of your nurse, the chief doctor in the department, and you need to have some criteria and protocols, because at the end, those are the ones that you're going to follow. And only discharge patient from the ED. It's not like you work in ED and then you go to gynae and try to discharge patient from gynae. So, conditions that we can see, and including this nurse-led discharge, are all of this, basically. You might realize that probably 80% of the patients that we have, or 60% of the patients that we have in our department, are pretty much all this. So we can take a huge responsibility in our department, but it's all depending on us. So I'm gonna make this more clear, how this works, okay? I put a scenario here. Ahmed is a 3-year-old child without asthma, viral induced with some wheezes. You do the first treatment when the patient arrives to our department, and after a couple of hours, 2 or 3 hours, the patient is being seen by the senior attending, but is still not ready to go home. So the consultant in charge said, okay, as soon as our patients fulfill all the criteria, the patient can go home. You don't need really to talk more with the consultant about that. Just follow your criteria. This is an example of the criteria that we can follow in our departments. So, you will be responsible to review the patient, do all the parents and child education, book any follow-up, check if all the medication is ready for that patient to go home. Complete all the forms, all the documentation, and be 100% sure that that patient is ready to go home. That's the more important part. And when all this is done, you're happy to go home. Bye, Ahmed. That's me after 10-hour shift. What are the benefits of a nurse-led discharge? There are plenty, okay? So, if you manage the flow in your department, you can avoid waiting times. The time and cost is better for your department, but also for the whole hospital. You can have robust discharge plans that it can be replicated for all the patients with these conditions that we previously mentioned. Family is going to be safer to go home because you are the one that is going to start all the education. And you don't need to wait until your department is full, and then you need to discharge some patients in a rush. It will reduce length of stay and readmissions. And overall, it's about us. We can grow a lot. We can develop our practice. We can take some lead in all this. And we gain more autonomy as a nurse. So, to take home message, I told you that it's going to be quick. This is not about transfer all the responsibility from the doctor to the nurse. You should have in your department protocols and criteria, and it should be a multidisciplinary decision. You should be able to take clinical decisions and being able to assess your patients, being an expert with full training and competencies, and overall educate really well your patient and your family. No questions? Thank you. Any questions?
Thank you for that. We have a question here. It says that in this culture where the trust is more on the doctors than the nurses, how do you meet this challenge?
I think it's all about us. So in this culture, in the past, there were no advanced nurse practitioners, and nowadays you have nurse practitioners that take decisions. I discharge patients every day from our department, and I don't need to talk with any doctors. So if I can do it, I think that anybody can do it. It's only to try to promote this role, and yeah, talk to your managers, talk to your chief. I know that it's going to be not easy, but if I can do it, I think you can do it. We are an example, I think, that we are able to do it. You don't need to be a genius, to be honest. Right?
Yeah. Thank you for that.
Okay.
There's a follow-up question.
Okay.
Okay. Do you have any data that supports the rate of readmissions for patients that were nurse-led discharge?
Yes. So Lee, the author that I named before, they said that if you start if the nurse-led discharge is in place, the readmission rate is low. The reason is that the education that you do with your patient in the emergency department is better. It's basically a nurse dedicated to you to give you all the information. Nowadays, our emergency departments are so crowded, so at the end of the day, what you do is you give a paper to the patient and you say, you can go home. If you do this education and you try to educate these patients with more time, usually the length of stay and also the reattendance is lower, and it's been shown.
Any other question from the audience? Thank you, Carlos.
Thank you.
Education is power. This will really give empowerment to nurses. Now let's call on our next speaker. That's Ms. Jorna. She will be talking about application of capnography in pediatric emergency department. She is one of our RT supervisor in HMC.
Good afternoon. So the title of my presentation is the application of capnography in pediatric emergency department that we started last year. I don't have any relevant financial relationship with commercial interest to disclose. Our learning objectives is at the end of these presentations, we will be understanding the importance of why we need to monitor capnography in spontaneous breathing patient and what are the valuable information that it can provide for patient assessment and for patient treatment. Capnography, when you say capnography, there is sometimes confusion. When you say capnography, you are measuring the end-tidal CO2 plus there is also the values or the waveform. When you say capnometer, you are just taking the measurement of the end-tidal CO2. End-tidal CO2 is a reflection of alveolar ventilation, the CO2 production, and the pulmonary blood flow. It refers to the gradients measure of the partial pressure of carbon dioxide. It was first established in 1930s and clinically used end-tidal CO2 measurements as the continuous technology advancements in 1950. More generally, end-tidal CO2 monitoring or capnography is being used in general anesthesia, procedure sedation, analysis mechanical ventilator in patient admitted on ICUs, cardiac arrest to confirm tracheal intubation, and if, for example, we want to make sure that we have adequate chest compression during the CPR. And nowadays, end-tidal CO2 or capnography is being used to confirm adequate ventilation for patients spontaneously breathing. In July 2013, an emergency medicine published an article titled Capnography for Non-Intubated Patient in Emergency Setting. This journal discussed that capnography can be an effective tool of measuring adequate ventilation and the rate of the patient receiving narcotics, analgesia, benzodiazepams, and if the patient also on seizure medication. In measuring the capnography, we can use the nasal prongs, which is always available. If the patient needing an increased oxygen demand, we can also use the simple mask. And if the patient, for example, is needing positive pressure ventilation, we can attach the capnography to the interface when the patient is on CPAP or on BiPAP. What are the indication of capnography in spontaneous breathing patient? Respiratory distress is usually common in patient complication in pediatric population, especially in pediatric department. Waveform capnography is a valuable tool to determine the cause and severity of the respiratory distress. We can easily determine and assess if the patient is already hypoventilating, if the patient already there is an increase on CO2 level. And we can really assess if the patient immediately need positive pressure ventilation. Another thing is to monitor the patient response to treatment. For example, if in collaboration with the nurses, in collaboration with the respiratory therapy, especially as our experience in pediatric emergency, as said, we have only one respiratory therapy assigned in the emergency. And the valuable information from the nurses itself, for example, the nurses give an albuterol, and then there was a changes on the waveform of the capnography, and then immediately the nurses will inform the respiratory therapy. This time, if, for example, there was a shark pin on the waveform of the capnography, and then suddenly after delivering albuterol, the shark spin becomes square or become rectangular, it means to say there is a patient response to the treatment. If, for example, you just connected the patient on a positive pressure ventilation and your waveform or the measurement of your end-tidal CO2 are high, and after delivering a few seconds of a positive pressure ventilation, immediately the waveform or the end-tidal CO2 goes towards normal. So it means to say we can detect and check the response of patient to treatment. Capnography also detects shocks. What are the pathophysiology and the causes of high CO2? High CO2 can be, number one, will be the malignant hyperthermia, increased muscle activity, shivering, fever, sepsis, and endocrine diseases, hyperventilation when there is a decrease on minute ventilation. And then cause of low end-tidal CO2 can be decrease on muscle activity, hypothermia, low cardiac output, pulmonary embolism, hyperventilation, increase in minute ventilation. This is the normal capnography and the phases. So we have the phase 1, which is the beginning of the expiration. It's equal to anatomical dead space without a measurement of the carbon dioxide. The phase 2 is B to C, which is the rapid rise of CO2 concentration, which is the starts of the upset of the expiration. And the phase 3 is from C to D, which is the expiratory plateau, and the D, it's where we capture the measurement of end-tidal CO2. And the phase 4, from D to E, is the start of inspiration. So from phase 1, phase 2, and phase 3, this is all expiratory phase, and the phase 4 is the beginning of the inspiration. So usually, when we are monitoring the capnograph, it's always on rectangular waveform. The normal values for PaCO2 is 35 to 45, while the normal values for the EtCO2 is 30 to 43 millimeter mercury. We just capture some of the abnormal waveform that can be seen on pediatric emergencies. For pediatric emergencies, number 1 is the absence of end-tidal CO2. You can see there is no phase 1, phase 2, phase 3. It can be an apnea. Number 3 is the airway obstruction. Can you see the shark's fin? It indicates that patient may be asthmatic or COPD. And then increase in end-tidal CO2 level from normal. If the patient, for example, is hypoventilating, decreasing end-tidal CO2 level towards normal. For example, the patient CO2 is 50, and after connecting the patient on positive pressure ventilator, it went toward normal. Reduce end-tidal CO2 level. If you can see that they are trying to attempt a 10 millimeter mercury, this is when you are doing the CPR. Curie cliff is when this is a waveform when the patient is connected on mechanical ventilator and they are trying to decrease the sedation. During expiratory phase, the patient is trying to do inspiration. Sudden significant increase in end-tidal CO2 when you are doing the cardiac compression, and suddenly there was an increased perfusion, so there was an increase on end-tidal CO2. Now, the last one is the increase in end-tidal CO2 value towards normal when the patient reached a normal end-tidal CO2. Take-home message: the shape of the capnography waveform helps us to determine the cause of the problem. Think that respiratory failure when end-tidal CO2 is high. Think perfusion, metabolic, or physiological problem when end-tidal CO2 is low. Capnography provides the real-time feedback on response to treatment. Hypoventilation with a bag valve mask is harmful, and capnography can help to prevent it. Thank you.
Do we have any questions for Ms. Jorna? There's also no question from the app, so we can call the next speaker.
So the last but not the least, definitely, Ms. Samantha, who will be talking about distraction technique for the pediatric patient in a nutshell.
All right, like everybody else, I have no financial disclosures. At the end of this presentation, you'll be able to talk about different ways to distract children. So if everybody could just start reading this, it's a big slide, so if you could just focus, really get to know the content, that'd be great. It's a rapid fire, so please read quickly. Hopefully you're almost done. All right, next slide. So distraction is something that prevents you from concentrating on something else. So in the case of housework and homework, it's not a good thing, but in the case of anxiety or a painful procedure, it is a good thing. So children need distraction for their medical procedures, their major sources of pain, anxiety, and distress. Even if you don't intend to cause harm, pain, or anxiety, the children might be feeling that. Pain that's not treated quickly or effectively has long-term consequences. So we need to employ different sources of distraction to help children through these times. So Hussein, 2012, has divided distraction into two types. Active distraction, where you're interacting with someone else. We're good with the bubbles in the corner now. So active distraction, where you're helping the patient along and you are interacting with them to provide that distraction. And a passive distraction, where the patient can just sit back and observe a distraction. It's not an interactive situation. So examples of active distraction are obviously toys. So if a little one can play with a truck while you're changing the dressing on their toe, that's a form of distraction. Video games is a great source of distraction, from homework, but also a really good opportunity for somebody to tune out of whatever procedure you're doing. So if they can play it one-handed while you're starting an IV, if they're really worried about, an abscess drainage, it's something else to look at. Virtual reality is a really nice one. Somebody who's anxious about the environment or, experiencing a lot of pain that just needs something else to focus on. Virtual reality is a nice trick to have. Controlled breathing, I use this a lot with IV initiation, so I'll say, all right, take a breath in through your nose and breathe out through your mouth. And so as you're starting the IV, the child inevitably starts to hyperventilate and panic a little bit, and I'll just remind them through that controlled breathing, and it's a really good technique to help them relax. Guided imagery and relaxation seems like one of those nursing school topics with doesn't really mean anything, but I use it a lot for procedural sedation. So I like to tell children before they get ketamine that we're going to pick what they dream about. And so I'll get feedback from them. So quite often the boys like to drive race cars and the little girls like to be princesses at a party. And so as I'm setting up and I'm giving them their medication, I'll say, all right, if you're a princess, what color dress are you going to wear? Do you have a crown or a tiara? If you're driving a race car, does it go on a racetrack or is it off-road? All these different things to help them focus on this image. Bubbles, obviously, some of you were distracted from that slide as I was blowing bubbles. You can auscultate almost any 2-year-old for a minute if you're blowing bubbles. They're going to forget about any stranger anxiety they have and focus on the bubbles, so it's really useful for assessment. Coloring is really good too. Sometimes it's boring having a nurse do a dressing change. So if you can give them some coloring tools and a space to do it while you do your thing, the child's going to end up a lot happier. Sing along. So this is where you get to test your repertoire. We've got some really good singers in the room. And if you know any really good kids song, it's a great tool. Having a story to read to them is always helpful. If your clinic has a supply of books that we can use, it's a helpful thing. Passive distraction is nice and easy. That's when you don't have help and you're really focusing on your task. You can play some music, your patient can listen to music, watch a little bit of TV, or another thing is distraction lights. Certain emergency departments will just have a light you can turn on and it just changes color and moves, and it's a nice soothing passive distraction. And I don't know, oh, my video didn't work. So if anybody does not know a song, Google Baby Shark. The lyrics are really easy. It will be stuck in your head for the rest of your life. And if you sing it with the children, they're going to think you're the greatest nurse ever. Any questions?
Question from the audience. I think we don't have any more, Sam. From the app, do we have? We don't have also. Thank you, Sam. I think that wraps up our activity for today. Have a rest for today and see you tomorrow.